lung carcinoma, causes, risk factors, pathophysiology, and management. Good morning, afternoon, evening, everyone. It is my honor to speak with you today on a topic that remains one of the most pressing concerns in the field of medicine and public health, lung carcinoma. Introduction. Lung carcinoma, or lung cancer, is one of the leading causes of cancer-related deaths worldwide. Despite advances in diagnostics and treatment, its prognosis remains poor, primarily due to late-stage detection. Today, I will be discussing the causes, risk factors, pathophysiology, and management of this devastating disease. Causes. The primary cause of lung carcinoma is prolonged exposure to carcinogens that damage the cells in the lungs. The most significant and well-established cause is tobacco smoking, which accounts for more than 85% of cases. Cigarette smoke contains over 60 known carcinogens that directly damage lung tissue. Other causes include secondhand smoke, exposure to radon gas, a naturally occurring radioactive gas, occupational exposures such as asbestos, arsenic, and diesel exhaust, air pollution, genetic mutations, or family history in some cases. Risk factors for lung carcinoma. A1, cigarette smoking. Most important risk factor. Accounts for approximately 90% of lung cancers in men and about 80% in women. The risk increases with the duration and number of cigarettes smoked, measured in pack years. Carcinogens in tobacco smoke, polycyclic aromatic hydrocarbons, PAHs, nitrosamines, benzopyrene, and others. Smoking induces chronic inflammation, metaplasia, and DNA mutations. Cessation reduces risk, but former smokers still have a higher risk compared to never smokers. 2. Environmental and occupational exposures. Asbestos. Workers in shipbuilding, construction, and insulation industries increases the risk of bronchogenic carcinoma, especially when combined with smoking. Radon gas. A naturally occurring radioactive gas found in soil and homes. Second leading cause after smoking. Uranium, arsenic, chromium, nickel, vinyl chloride, diesel exhaust. These industrial carcinogens contribute significantly. Air pollution. Exposure to fine particulate matter, PM 2.5, and other pollutants contributes to lung cancer risk, particularly in urban environments. 3. Genetic predisposition. Familial clustering of lung cancer has been observed. Polymorphisms in genes that detoxify carcinogens, for example, CYP1A1, or repair DNA damage, for example, XRCC1, ERCC1, can increase susceptibility. Mutations in tumor suppressor genes, for example, TP53, RB1, or oncogenes, for example, EGFR, KRAS, Alabama K, are more commonly found in tumors of individuals with no smoking history. 4. Pre-existing lung disease. Chronic obstructive pulmonary disease, COPD, and pulmonary fibrosis are associated with increased lung cancer risk even after accounting for smoking. Chronic inflammation plays a role in the progression to malignancy. 5. Radiation exposure. Prior therapeutic chest irradiation for other cancers, for example, Hodgkin lymphoma, breast cancer, increases risk. Survivors of atomic bomb radiation had higher lung cancer incidence. 6. Diet and lifestyle. Low intake of fruits and vegetables may be associated with increased risk due to reduced antioxidant protection. However, excessive beta-carotene supplementation in smokers was found to paradoxically increase lung cancer risk in some studies. 7. Age and gender. Lung cancer incidence increases with age, peaking in the 6th and the 7th of December AIDS. Historically more common in men, but the gap is narrowing due to increased smoking among women. 8. HIV infection. Increased risk due to immunosuppression and chronic inflammation, even when smoking status is controlled for. Pathophysiology. Lung carcinoma generally begins in the epithelial cells lining the bronchi or alveoli. Carcinogens such as tobacco, smoke cause genetic mutations in these cells, disrupting normal cellular repair and apoptotic pathways. This leads to uncontrolled cell proliferation, angiogenesis, and the formation of tumors. Lung carcinoma is classified into two main types: non-small cell lung carcinoma, NSCLC. About 85% of cases includes adenocarcinoma, squamous cell carcinoma, and large cell carcinoma. Small cell lung carcinoma, SCLC, about 15% of cases, highly aggressive and strongly linked to smoking. As the tumor grows, it may invade nearby structures, metastasize to distant organs like the liver, brain, and bones, and cause systemic effects such as weight loss and fatigue. Management. Management of lung carcinoma depends on the type, stage, and overall health of the patient. Key approaches include surgical intervention, preferred in early stage NSCLC. Options include lobectomy, pneumonectomy, or wedge resection. Radiation therapy, used when surgery is not feasible or in combination with other treatments. Chemotherapy, especially in SCLC or advanced NSCLC, helps shrink the tumor and prevent spread. Small cell lung carcinoma, SCLC, is a highly malignant tumor composed of small, round to oval cells with scant cytoplasm, finely granular chromatin, and high mitotic activity. It accounts for about 15% of all lung cancers and is strongly associated with cigarette smoking. Etiology and risk factors. Strongest link to smoking among all lung cancers, 95% of cases occur in smokers. Genetic mutations frequently seen. TP53 mutations, tilde 90% of cases. RB1 loss, 90% of cases. MYC family amplification, 20-40%. Not typically linked to environmental or occupational exposures alone without smoking. Location. Most SCLCs arise centrally near the hilum or major bronchi. Often presents as a large hilar mass with extensive lymph node involvement at diagnosis. Histopathology. Cells, small, round to oval, with scant cytoplasm, salt and pepper chromatin, no prominent nucleoli. High mitotic rate and extensive necrosis. Crush artifact is common on biopsy due to fragile tumor cells. Immunohistochemistry. Positive for neuroendocrine markers. Chromogranin A, synaptophysin, CD56NKM, as a party effect may be seen. Basophilic staining of vessel walls due to DNA deposition from necrotic tumor cells. Clinical features: very aggressive behavior with early metastasis to liver, brain, bone, and adrenal glands. Rapid doubling time and high growth fraction. Frequently associated with paraneoplastic syndromes, such as SIADH, syndrome of inappropriate antidiuretic hormone secretion. Cushing syndrome, ectopic ACTH production. Lambert-Eaton myasthenic syndrome, autoimmune disorder causing muscle weakness. Staging, traditionally classified into limited stage, confined to one hemithorax and within a single radiation port. Extensive stage, spread beyond the above boundaries. TNM staging is also used but less practical due to rapid progression. Management. SCLC is very sensitive to chemotherapy and radiotherapy, but recurrence is common and long-term survival is poor. Treatment strategy. Limited stage, chemoradiation. For example, cisplatin plus etoposide. Prophylactic cranial irradiation, PCI, to prevent brain metastases. Extensive stage, Chemotherapy is mainstay, cisplatin or carboplatin plus etoposide. Immunotherapy, for example, atezolizumab or durvalumab, has recently been added. Surgery is rarely an option due to early metastasis and central location. Prognosis, very poor compared to non-small cell lung cancers. Median survival, limited stage, approximately 15-20 months. Extensive stage, approximately 8-13 months. 5-year survival, 5%.